Okay, we're ready.
All right. So, good morning, folks. Good afternoon. Thank you for having me. First of all, I'm sorry to not be there in person with you today. I have an appointment at 9:30, so I'll need to leave after the presentation. But I'm happy to respond to questions via Teams or email for all. So, if you don't know me, my name is João Vitor Pérez Souza. I'm an assistant professor here at the Duke Department of Emergency Medicine. And here today, I would like to present to you our paper that was recently published on the PRACT R01 clinical trial, which was conducted in Moshi, Tanzania. In short, this paper is talks about the primary endpoint for the clinical trial, and it's called effectiveness of a brief intervention and text-based booster in the emergency department to reduce harmful and hazardous alcohol use. A pragmatic, randomized, adaptive clinical trial in Moshi, Tanzania. Um, I'm happy to say that this was published in October of last year in PLOS Medicine. I'm glad to be here presenting on behalf of my co-authors, which you might see a few of them in the call. Um, so without further ado, we don't have any disclosures. And this study was funded by the National Institute of Health, more specifically the Alcohol Abuse and Alcoholism Institute under an R01 grant for Dr. Staten. So overall, alcohol contributes to a 5% portion of the global disease burden. And unfortunately, Tanzania ranks as one of the highest in alcohol attributed mortality in the region. Um, and in past studies in Moshi and more specifically at the KCMC hospital, we found that about a third of the injured patients coming to the ED had some sort of report some sort of alcohol involvement in their injury. There are plenty of known ways to address the burden of alcohol in the population. And one of the prominent ways that is recommended by the WHO and by other institutions is the use of brief negotiation interventions, or brief interventions for short, which have been shown significant results to reduce harmful alcohol use in high income settings. The term there, brief, actually talks about the time. It's supposed to be a short intervention that has a meaningful impact in the patient's behavior change. And unfortunately, there is not a lot of evidence in low and middle income countries. And specifically for Tanzania, we did not have any culturally adapted interventions for the setting, which we know is a big thing. We don't want to, best studies actually reported uh, futility or lack of significant results. And a big limitation of these trials that were done at DED was a poor fidelity, but also poor adaptation to the setting. And we really wanted to address that in our study. Um, we see that there is an opportunity to address this gap in our setting, in the patient population specifically. Overall, because we see that an ED visit after an alcohol-related injury or after an injury overall is it's called a teachable moment, where the patient might be open for change and more respondent to change overall. And we saw an opportunity for a task shifting using nurses to deliver the intervention in our setting as well. Um, we really thought that we wanted to leverage an opportunity to extend the impact of intervention. So we also tested the impact of SMS text boosters to enhance the sustainability of our intervention. So overall, we wanted to address this gap by evaluating the effectiveness of a nurse-delivered, culturally adapted DNI with text message boosters in reducing binge drinking days at 3 months among injury ED patients in Moshi. And here, binge drinking days specifically means a day that a patient consumes, a male patients consume more than 4 drinks, and a female consumes more than 5 drinks. Or maybe I got the numbers wrong. but the two of them. Essentially, binge drinking days have been linked to injuries, to risky behavior, to RTIs, and reducing that could overall increase population health outcomes in our setting. Getting to the methods, this was a pragmatic adaptive randomized control trial, which we call PRACT. We applied a 3-arm randomization in the sense that all participants were equally split between the 3 arms that we were studying with a block size of 12. We had an intention to treat analysis, framing, and we had pre-specified interim analyses with O'Brien-Fleming stopping boundaries. All of this to say that with the pragmatic design of this study, we had early stopping points for analyses where if we found a significant effect, we were able to adapt the design of the trial to proceed to a phase 2 in order to provide the best quality of care for our participants. So in essence, if we detected a significant effect of intervention, we could drop the usual care and proceed to step 2, which was then a separate comparison. We obtained all the appropriate regulatory approvals from Duke for the KCMC College Ethics Committee and from the Tanzania National Institute of Medical Research. The study was conducted at the KCMC Hospital, and more specifically the KCMC ED in Moshi, Tanzania, and KCMC is a major referral hospital in northern Tanzania. Our participants overall, eligibility criteria here was that they had to be adults above 18 years old. They needed to arrive to the KCMC with an acute injury, so in the past 24 hours, which we thought was the best window to intervene in these patients and then deliver the intervention as well. And in terms of alcohol, they had to be positive upon arrival. And then positivity here actually means either scoring 8 or above in the audit test, reported drinking prior to injury, or having a positive test on the breathalyzer. We excluded participants that were not fluent in Swahili, that did not have any phone access because of the nature of one of our intervention arms. We wanted to use the text boosters for sustainability. They were not living in East Africa in the last 5 years and that were unable to consent. Overall, our team would approach the participants either at ED or the wards once they were clinically sober. And our team approached them in multiple occasions in case they were, in too much pain. They were doing their treatment course. We tried a few times in order to enroll as many participants as we could. This is a simplified diagram of how our enrollment would occur. So overall, all KCMC ED injury patients would be considered and assessed for this pre-screening step, which is their age, being there for an acute injury, consenting to be assessed for eligibility. If they would pass this pre-screening, we then assess their alcohol criteria. So as I said, audit, breathalyzer, or alcohol use. And then they will be randomized either to usual care or to the PPK plus tax reminders. In more detail, the PPK intervention also means the Punguza Pombe kwa Afya Yako, or reduce alcohol for your health in Swahili. It was a 15-minute nurse-delivered motivation intervention where the nurse would engage with the patient in a reserved location. They would follow a structured guideline, a script where they would raise the topic of alcohol, they would provide feedback, and enhance motivation and negotiate goals with the participants. Patients that would participate that were randomized to the booster arms would also would receive the intervention, and then for an additional year, they would receive text messages on their phone every week that were either standard or personalized. Standard meaning it was a common set of message for all participants, and personalized means that the participant would report, for instance, why did they want to reduce their alcohol intake or their alcohol use behavior. Maybe, for instance, one of them would say, I want to reduce the amount of alcohol that I consume because I want to spend more time with my family. So we would include some of that language in the message they would receive in the personalized form. And usual care would be no routine alcohol screening or counseling. Our outcomes here were mostly pretty much self-reported, and this is an important piece on that I want to get into the discussion. Our primary outcome here and our primary endpoint was at the 3 months post-discharge, which were the change in binge drinking days in the past 28 days. We also analyzed secondary outcomes like the number of drinks consumed in the past 28 days, the number of drinking days, or the patient reporting drinking at least one time, one standard drink actually, in the past 28 days. But also we had the alcohol use disorder identification test, the drinking inventory of consequences, and the patient health questionnaire, which are composite like scores that we would measure either their alcohol use consequences, the behavior, and also some mental health information on the PHQ-9 specifically, as we know that alcohol consumption is related to mental health conditions as well. We did follow our participants via phone at 3, 6, 9, 12, and 24 months, but this study focuses on the 3 months outcomes, which were our primary endpoint in our powered sample size. In terms of statistical analysis, we performed a constrained longitudinal analysis, and this is because we had a slight difference in the outcome levels at baseline despite the randomization. So we adjust for that in order to detect meaningful results. And the impact of the intervention was modeled with either a mixed effect, zero inflated negative binomial model. I know that's a mouthful, or a mixed effect negative binomial model, or a linear mixed effect model, depending on the nature of the outcome. Specifically, our main outcome, binge drinking days, is an outcome that naturally has a lot of zeros. So if you do not drink either 4 or 5 drinks, as Catherine shared in chat, this essentially means is zero in the event for the binge drinking. And this is really hard to model with standard techniques. So that's why we use the zero inflated model here for this specific outcome. We also perform missing data imputation with a method called multiple imputation by chained equation, or MICE. And we performed a series of sensitivity analysis in our data results, specifically focusing on the impact of the imputation, the impact of outliers in our sample, and also the impact of the modeling approach in the results that we were seeing. All right, getting to the results. So as I told you, this study focuses on the primary endpoint. And so this reflects data that is back from maybe late 2023 in terms of enrollment. At the time, we had assessed for eligibility about 1,500 patients, of which 448 were randomized. Let me see if I can get the laser pointer. Yes. From this 448, 148 of them were located to usual care and 300 for the intervention. And here we see this 2-to-1 ratio for the intervention because we are comparing the 2 booster arms combined versus usual care. In stage 1, which is this study focuses, we want to see is any form of intervention better than usual care. That's why we have a 2-to-1 ratio here. From the 148 on usual care, we analyzed 123 participants' data, in which 18 of them had incomplete data. From the intervention 300, we dropped 54 participants either because they weren't reachable, because we missed them in the term of the follow-up. We had to withdraw the patients and other reasons, and we ended up with 246 and 205 with complete data. And we really wanted to make this clear here on the incomplete part because that's where the missing imputation comes into place. And we wanted to really make it clear how many patients we had to impute and work through the results. All right. So this is our baseline demographics information for the study sample. We have here the number of patients included overall, 369, and across the two arms, as I told you. Overall, our sample had a median age of 34. Most of our participants were male, which is common, which is similar to the prior studies that we had done in the setting, and also similar studies that we saw for either injured participants and also alcohol-related injuries as well. The majority of our participants were from the Chaga tribe, which is corresponds to the distribution of the population in Moshi as well. Okay, getting to the primary and secondary outcomes. So these are the observed values. So what are the averages, the medians, etc., for the outcome measures that we had, metrics that we had observed. More specifically, I would like to get your attention to the binge drinking days. So overall, our population had an average of 2.2 binge drinking days or 3 binge drinking days at baseline. So they reported this when they got their injury. And you can see there's a slight difference here from the 2.2 to 3, and that's why we did that analysis to account for that. After the intervention, so after the 3 months, either both groups, both usual care and intervention, had a reduction in their binge drinking behavior. So you can see how the 2.2 reduced to 0.8 and the 3 reduced to 0.4. But then we wanted to measure how much better or how much worse, how the intervention performed compared to the usual care as well. And as I said, you can see here how the median of our data is 0 at baseline, and at 3 months, actually both median and the interquartile ranges are also 0. So this is where with the modeling with the zero inflated would be important because of how sparsely populated, I want to say, the data is, and how rare the event is actually. We also had a similar number of drinking days across the population at baseline, so 7.4 and 7.7. And this was also reduced to 2.9 and 1.4 after the 3 months for all in both groups. Then continuing for the other outcomes, we have here specifically the PHQ-9 score. You can see how overall the mental health values that we're measuring here at baseline were slightly lower than at 3 months. So this was a specific concern that we had at first. If we are intervening with the alcohol use behavior, are we in any form causing harm or not on the mental health conditions for these participants? So this is one thing we're going to look at specifically as well. And as for the audit score and drink score, we see that there was also a pattern of reduction for both metrics at 3 months in both groups. But then let's talk about the results on intervention itself. So the results that I just showed you were the observed values, and now we are now looking at the modeled values where we're taking into account the individual level fluctuation and the impact of intervention or usual care at 3 months. This figure shows the reduction in the number of binge drinking days from baseline to 3 months following up intervention and usual care in a difference between the groups. So if you look here, we have usual care, intervention, and the axis here is negative because we are getting a reduction in the average number of binge drinking days for these two groups. You can see how both groups had a reduction, so minus 1.7 and minus 2.9 on the intervention. And these two are on themselves are significant reductions from baseline. But then when we compare the two groups across themselves, we see this relative difference of negative 1.2 that shows us that on average, the PPK intervention reduced an additional 1.2 days in their binge drinking events. And this is statistically significant, and the range here is from negative 2.3 to 0.3, the confidence interval. The panel B shows the distribution of this effect. And this is part of our sensitivity analysis as well, showing how even though we get the average, it's always important to look at the distribution of the cases of this difference. So we see how many outliers there are and how does this behave. Then here, let me see if I have a highlight. I think I do, yes. So then looking at the secondary outcomes, which we were not powered for, this is not our main focus, but I want to get your attention on how we did see more significant reductions, more meaningful reductions in the intervention group for both the drinking days, the drinking amount. This is the relative difference between the two groups, and the audit and drink values as well. Although these differences seem to highlight an overall pattern of change, we cannot say for sure that these results cannot tell for sure because our sample was not powered for this analysis. And in the PHQ-9, as I told you, we were concerned of this possible situation with the mental health scores. We saw an increase in the intervention group, but this was not statistically significant as well. Oops. There we go. All right. Getting to the discussion here. This was the first pragmatic adapted randomized controlled trial of alcohol harm reduction in an ED in a low and middle income country. And more specifically, we want to highlight how this was designed and was tailored to function in the setting that we had. I think I have a part on this later, but a big part of our study, the relevance of our study was on the fidelity and how flexible we were through the design. So all of the interventions that were performed, a portion of them were recorded and then were assessed for quality. And if our staff would note that there was anything that could be improved during the PPK intervention, they would give feedback for the nurses. They would do retraining if needed in order to ensure that throughout time, because we were enrolling patients across a number of years, that the quality of the delivery was sustained. We saw a big reduction. So we saw a 1.2 reduction on our intervention group compared to the usual care. Although this might not look as much, as I told you, the binge drinking days are really important because the injury risk increases non-linearity with the binge drinking events. Usually when it's on these binge drinking events where the patients are going to engage in risky behavior, and even small reductions in this high risk drinking can have public health impact overall. And all of this with a 15-minute intervention done at DD by nurses and with these weekly text reminders. Here, we see a short-term effectiveness in a real-world setting. As I was telling you before, we had prior ED trials, such as the ED SIPS, that was performed in UK that showed no results. But a big limitation of those trials was on the fidelity and how tailored they were to the population. We built a structured fidelity monitoring. Yeah, I see it now with the recordings, feedbacks, as I just said, in order to address that. Not in order to address the issues as they would arise and be flexible in our conduction. This was also a culturally adapted intervention for the Tanzanian context, and we also have a paper describing the process of this adaptation on starting from a endorsed model such as the motivational interview concepts and adapting to the Tanzanian context, either by adapting how the intervention was delivered, what questions were made, and even the topics that were raised to adapt to the actual setting. Sorry. We included a broader AUD spectrum due to limited treatment and availability. Essentially, usually if you go to the literature, the audit score range for brief intervention is either between 8 and 18. which can vary some in different literature. But overall, you get this population of participants that the patients that are not really severe. While in our sample, we did not make such a exclusion. We included everyone because we also saw, because of the limited availability of treatment overall in Tanzania. This in turn could have masked some of the effects that we would see if we would focus on this at like average risk population, because overall, if you had a severe alcohol use disorder, you'd be referred to special care in other settings. We had a robust set of sensitivity analysis to ensure that our results were reliable. We did see overall, regardless of doing the imputation, the modeling approaches, and others, we saw a constant behavior, a similar behavior across results, either in terms of magnitude of effect, but also in directionality, which is the most important. In terms of limitations, our study used this self-reported alcohol use or self-reported metrics, which there is a trade-off between what we can actually do and measure in their real life versus the limitations of including the bias, the reporting, social desirability bias in that sense. So that's important to look at. All of our metrics, all of our drinking days and drinking outcomes would be following the timeline follow back method, where we would go with the patient ask them in the past day, how many drinks did you have? In the past 2 days, how many drinks do you have, in order to have a structured feedback in the numbers and include the reliability of the results. We do focus here on short-term follow-up, and essentially our stage 1 here is at 3 months. This was our primary endpoint. We cannot say for now what are the long-term effects, but I can tell you that this is underway. The analysis is underway right now. Phone access may limit the generalizability, you got the picture, of our results, but we do see that a majority of the population in Tanzania has access to phones, either at, in our setting specifically, either at a personal phone or a shared phone that they could use to receive the text messages. We addressed the baseline imbalance in our sample, and we do see a reduction in both arms, which can also be, of course, this effect of the teachable moment in itself. But we did the appropriate methods to control for that. In terms of conclusion and perspectives, we see that our results support implementation of culturally adapted BI in a Tanzanian ED. The stage 2, we will actually look at the necessity of having the text boosters message at all. The question is the PPK intervention enough, or do we actually need the boosters to improve the effect? We are looking at the long-term follow-up effect and the mediator-moderator analysis as of now. And of course, there's a potential for expansion beyond the injury population as well. Thank you for your time.
Thanks, Joao. Oops. Thanks, Joao. Do you need to drop off?
I do, folks. I'm sorry for the rush. I have something else at 9:30, but please let me know if you have questions or you would like to know more afterwards.
Or I'm happy to answer questions as well. Thanks, Joao Victor.
Yes.
Thanks, Joao.
Thank you.
So any questions, comments for Catherine?
I know he did such a good presentation. No questions, right?
Yeah.
Well, good morning, everyone. This is
I don't have a
Donaldson.
question.
Oh,
Sure. Go ahead, Donaldson, and then we'll come to next question.
oh, there was another question. My question is less about the actual results, but more about the process, because as you are aware, I'm currently getting ready to launch a project on RCT in Arusha, and I'm just trying to wrap my head around everything that goes into a randomized control trial as a new PI. So I just wanted to know if you could share a little bit about what were some of the challenges you experienced with recruitment. I think he mentioned the methods process and having the final sample size, but anything you can share and how it was handled, especially with managing teams, data collection, cleaning the data. I think you have Swahili being administered in Swahili, then having it translated, and then eventually having somebody clean it. I mean, it might be another conversation needed, but in case you can share.
Yeah. Great questions. And honestly, it could be a whole hour-long discussion of all of these things. I'm happy to talk more offline. I would say the first thing about doing a trial is that it's far more complex than you ever think about, especially when you're balancing the differences between research and practice, like in true implementation. And you have to make some very early decisions, and you have to document every decision you make. Because if it's implementation, that's fine. You can change it without a problem, but it's a clinical trial. And so you're going to have to be able to justify every decision you make along the way. And so many of the times we made group decisions so that we could group think about the challenges that we're going to face. So it was usually 3 or 4 of us in a room essentially saying, this is the problem we're facing. This is the issue we think it is. We're not fully sure why this is happening. What are the ways that we can address this? And then how does that go along with our goals of a pragmatic implementation, but still being able to demonstrate effectiveness? And sometimes it required a lot of discussion. The other thing is to be very responsive. So you have to, I don't want to use the words micromanage, but you have to be very on top of the data as it's coming in. One of the things that we ended up seeing is that we started to see some quality issues because there was a communication or a process issue. And so we very quickly had to say, okay, we're seeing some quality issues. What is the problem here with follow-up? And then we weren't getting enough information to our team in Tanzania to when they needed to do the follow-up. And so we organized a system to be able to get them that information. And then the quality was excellent because our team is really good. They just needed the process to be able to understand when they needed to do follow-up in an organized fashion. And so there needs to be a high level of management and self-evaluation to make sure that you are on top of when things are happening, especially if it's your first trial. For me, it was my first trial as well, and we learned so much in the management of the trial, never mind the management of the analysis. We also chose some things that we hate ourselves for, like our outcome measure was so difficult to analyze, and we really wish we used a different one, but it was helpful, and it was what people had suggested we use. In our setting, it was not the right one. And you will make errors like this. And that's okay, as long as you're able to remember why you made these choices and make the discussion at that time and keep that information, you'll be able to justify it downstream. And then when it comes to managing in different languages, this is the best part of global health. This is how you build a team and really partner with the people on the ground, because honestly, our Tanzanian partners really wanted this to work. And that's what makes this whole teamwork and process work, is in the fact that they were empowered to make it their own, to really want this to work as much as we did, to partner and understand why we were doing the things we were doing, to be able to ensure quality, but at the same time create a system that was reproducible for implementation. Because we really wanted that to be implementation focused and not a quality program that's just going to fall away as soon as we stop the research process. So we made it very much in line with what was the ongoing processes. So Donaldson, happy to talk more about it. I think especially as a new investigator, talking to other people who are doing randomized control trials is important, especially if you're choosing these pragmatic trials, which are as close as possible to ongoing care. Great question.
Thank you so much. All right.
Of course. Bruna.
Okay, I'm here. I forgot. Sorry. I was trying to build my question in English. Please, if I couldn't, please help me because it's a little big. Well, I have first of all, amazing work because it's all the process made me change and think about. And one of the things that I really would to know is about these patients will be found in the hospital, yes, in the first moment, and after some issues from the alcohol use. But how this context will influence and all the process, because maybe these patients will be in the sixth stage of the change, maybe in the preparation in this case. And sometimes my question here is how we can for all these knowledge from this study, how we can find another patients in another stages of this behavior change, you know? I
understand. Yep.
Okay.
Great question. So the brief motivational interview, or the brief intervention, which is what this is, uses motivational interviewing techniques to help people move from a pre-contemplative stage to an action stage. Many of the patients that we saw in the emergency department who suffered an injury and came to the emergency department were pre-contemplative. They did not understand that they might have too much alcohol use and they had consequences. So while some of them might have been more ready to make change, most of them were not. And that's the basis for the intervention, is that it moves you towards this action phase and gives you some specific tools to be able to make small, self-determined changes, meaning my changes, what I choose might be different from what you choose. And that's okay. And we didn't actually measure how different your and my goals were. We measured what the overall change was, which again, that could very much impact my results, right? So if I only wanted to reduce 1 drink and you wanted to reduce 5, ultimately it'll move us towards a safer amount of alcohol use, but it might be very different in our overall results for the trial, right? So from a pragmatic nature, that's poor for results. But for a personal nature, that's a really important activity and action. So what's inherent in the intervention itself is it should be able to work for anybody who is in any stage of motivation or non-motivation for change. And the team themselves were supported to help people along that behavior change pathway. To change. I don't think we had very many people who chose to do nothing as their intended behavior change process. I would have to ask the nurses to see how many people that was. We did have some patients who were determined to be challenging, meaning they probably were a little bit more resistant to any of the behavior change. Whether or not they came up with a choice of, I don't want to change anything in the conversation or not, I'm not sure. We didn't look that in depth. We wanted to look more of a systems level approach. There will always be people who are like that, and that's okay. They might not benefit from this, but on the whole, the population really benefited from the in-person communication, from the empathetic support the nurses gave them, from the knowledge gained, and the tools to be able to make small behavior change activities. And at that point, you hope that they feel the improvement in the reduction of alcohol, and at which point that they continue those activities themselves. And so that's all kind of nested within the intervention, and we could talk for another hour about just what that intervention looks like. Great question.
Thank you.
Yep.
Carl, do you have a question?
I do, but my question's kind of turning more towards being a multi-part question that should probably be held for a later discussion, just because I know the answer is going to be pretty long. So I'll meet with Dr. D'Souza offline and ask him.
Awesome.
Okay.
Sounds good. Thanks, Carl.
Thanks, Catherine.
Excellent. Well, thank you to the team in Tanzania and our analysis team here at Duke. Thanks you guys for a really job well done.
Great. Let me